we're going to review what you need to know for Part 1, Case 2 of the OCE. Now, Case 2 mostly deals with treatment and covers these 5 areas. So, Part 1, developing a treatment plan. Number 2, developing goals and patient collaboration. Number 3, collaboration, consultation, and referral to others. Number 4, monitoring, reassessing, and modifying the plan and/or promoting self-care. And number 5, discharge planning or transitioning care. All right, I love examples, and I feel like examples are the best way to explain a concept. So let's give you an example for Part 1, Case 2. Klaus, an 82-year-old retired coal miner, fell while walking to the dining hall. He was rushed to the emergency and was diagnosed with a right femur fracture. Klaus underwent surgery, and the fracture was fixated with an intermedullary nail and screw. Prior to the fall, Klaus required minimal assistance with dressing and bathing and was independent ambulating with a single-point cane. Klaus is currently 3 days post-op and is not yet mobilized due to his post-operative delirium. He has refused to mobilize due to right hip and lower leg pain. He is confused and only orientated to person. His son and daughter are actively involved and have both been in and out of the hospital to see their father. Klaus tends to be more relaxed and comfortable in the presence of his children. The patient record indicates possible head injury from fall and was cleared by a CT scan in the emergency. Recently diagnosed with early stage pulmonary fibrosis. Klaus currently requires oxygen at 3 liters a minute via nasal cannulas due to his dyspnea at rest. Comorbidities include hypertension, type 2 diabetes, and hepatitis C, and Klaus wears glasses. The core question for this case is, what would your treatment plan be for this patient? You have 5 minutes to formulate an answer for all your core questions. If you want to use this as true practice for the OCE, we encourage you to pause the video and take 5 minutes to write down your answer. Let's review this question for Part 1, Case 2, developing a treatment plan using PT Exam Prep's approach. Now, I promise you, we're gonna make this really easy. So if you're stressed about Case 2, listen up and it's gonna become much simpler. So we're always gonna use the same 3-step approach for formulating an answer to the core question of your treatment plan. So number 1, you're gonna create a problem list. Problem list is incredibly important. You're going to go through the case, you're going to pick out all the main problems. Then next, you're going to select 2 to 3 treatments per problem, right? And then you're going to verbalize each treatment and why you selected it. Creating a problem list is going to help you immensely as you go through Case 2, okay? You can refer to it as you answer all the questions in Case 2. So seriously, get really good at creating a problem list. Okay. Your problem list should be based on the patient's condition and status presented in the case. So, for example, if pain is not listed as an issue, do not include it as a problem. If you want to take a few minutes and go back to look at what you did when you answered that question, do that now and try to create your treatment plan based on those 3 questions. So, create a problem list, select 2 to 3 treatments for each problem list, and then you'd verbalize your treatment as well as your rationale. Okay, let's put those 3 steps into action and let's go over the first part, creating a problem list. So here's the thing, remember, your problem list is going to be different than mine. It should be different than mine. We want to make sure that we're still covering the main problems that are in the case, but yours may be worded slightly different based off of your clinical experience, your clinical reasoning. Don't worry, that's not a bad thing, but take some time and make sure you know how to do a strong problem list. These are the problems we would choose for this case. Number 1, postoperative right hip and lower leg pain. Number 2, confusion or delirium and refusal to participate in physiotherapy. Number 3, dyspnea at rest requiring oxygen support. Number 4, history of pulmonary fibrosis. Number 5, decreased mobility with feather weight-bearing status. Number 6, increased risk of DVT, post-surgical and not mobilizing. And number 7, comorbidities, hypertension, type 2 diabetes, and hepatitis C. Now, for each problem, you're going to select 2 to 3 treatments, okay? Now, there may be some overlap. You may use the same treatment for multiple problems. That's okay, all right? And then step 3, the last part, you're going to verbalize your treatment plan and explain your rationale when doing this, okay? So it's really important to make sure that you're explaining your rationale, because this allows the examiner to clearly understand your reasoning for why you're choosing that treatment. Let's now go through each of the 7 problems and highlight the treatment options we could use to manage the problem and why they were chosen. Let's start with problem number 1. Post-operative right hip and lower leg pain. Treatment options could include coordinating with nursing to time physiotherapy treatment with pain medications to improve pain management and increase patient participation, decrease pain using positioning in bed, which could limit the strain on the painful post-operative limb. For example, they could go into side lying on the unaffected leg with a pillow between the knee. Another option could include cryotherapy, as it does help decrease inflammation and pain. However, when you are teaching or using cryotherapy as a treatment, you would need to make sure that you are teaching or clearing contraindications. But because the patient can't reliably tell you about their sensation, given their current stage of delirium, this would not be a good treatment option at this time. It could be an option once their post-op delirium has passed. Problem 2, confusion or delirium and refusal to participate in physiotherapy. Treatment options could include timing physiotherapy so it occurs when the patient is less confused or delirious. There is a fluctuating nature to delirium. For example, they're often worse at night and upon waking, so you would want to be aware of this. You could time physiotherapy for when the son or daughter is present, as the case does state they have a calming effect on their father and may be able to encourage him to participate. You could teach the son or daughter exercises so that they can encourage or assist their father during the day when maybe physio isn't available or present. You could use effective communication strategies for delirium to increase participation in physio sessions, such as be patient and give the patient time to speak, gain their interest in participating. You could ask them what they like to do. You could allow the patient to choose between 2 activities so they are more willing to participate. And you could limit distractions to ensure a quiet space for the sessions. Use clear single-step instructions, or if necessary, use gestures, demonstrations, and visual cues instead of a lot of talking. Problem 3, dyspnea at rest requiring oxygen support. Now, it's important to consider that we don't necessarily know if their low O2 is due to their pulmonary fibrosis or potentially it's due to post-operative shallow breathing. It's not clear based on the information presented, so it would be important to consider both as contributing factors to the low SpO2 levels. So, treatment options could include positioning to minimize feelings of dyspnea, such as high Fowlers, begin mobilizing, as this can increase ventilation and improve O2 levels if some of the dyspnea is actually due to post-op anesthesia and shallow breathing. You could even do things like bed mobility, rolling, supine to sit, sitting up in a chair. You could prescribe deep breathing exercises to maximize ventilation and improve their SpO2 levels. This would be more suited once the post-op delirium improves or clears. This could include diaphragmatic breathing with or without inspiratory hold, breath stacking with or without inspiratory hold, incentive spirometry. It would improve overall strength and activation of muscles for breathing, optimize ventilation and lung volumes, and reduce work of breathing. Problem number 4, history of pulmonary fibrosis. Treatment options could include ensure short bouts of activity or mobility, for example, 15 minutes of sitting in a chair and progressing them as able. You would want to monitor their SpO2 to ensure adequate oxygenation while mobilizing. With pulmonary fibrosis, you also need to avoid overexertion. Deep breathing exercises would be great as able to increase lung expansion and ventilation. For example, diaphragmatic breathing, breath stacking, inspiratory holds, incentive spirometry, and of course you want to make sure that they're able to do this based on their delirium. This would most likely be something that you would initiate later once the patient is less confused and able to follow instructions. As a future treatment option, when the post-op delirium has subsided, we could teach them energy conservation, pacing and planning strategies to help with fatigue and dyspnea management. Problem number 5, decreased mobility with feather weight-bearing status. Treatment options could include beginning mobilizing as soon as possible to decrease the negative effects of immobility. You would want to avoid any standing at this point, as it would be unpredictable if the patient could follow the prescribed weight-bearing status. You could do things like bed mobility, like rolling or supine to sit, sitting at the edge of the bed, and even assisted transfers to the wheelchair without breaking weight-bearing precautions, a slide board, or potentially even a mechanical lift. You would want to ensure that while you're mobilizing the patient, you're maintaining the integrity of any lines or tubes, such as his oxygen. You could use the portable O2 tank if necessary, and you'd want to make sure that there's no pulling or tension on the oxygen tubing, as it could pull it away from the patient's nose. You could assist with bed exercises to encourage range of motion and muscle activation when limited, or would be limited, by their current weight-bearing status. You could include gentle passive range of motion and active assisted range of motion as able for the lower extremities. Things in supine you could do could be heel slides, ankle pumps, hip abduction in supine, quadriceps setting, glute squeezes. You could also do in sitting knee extension or kicks. You could have the family assist with encouraging the patient's participation and increase exercise reps while the PT is not present. Problem number 6, increased risk of DVT, post-surgical and not mobilizing. Treatment options could include monitoring for a DVT. You would inspect the calf bilaterally, looking for redness, swelling, warmth, or tenderness. You would perform Homan's test, which you would do by passively dorsiflecting the leg with the knee extended. If a DVT is suspected, you would not mobilize and immediately report to the team, nursing staff, or the physician. You would promote the use of compression socks to help prevent blood pooling, teach ankle pumps to assist with circulation, perform active range of motion or passive range of motion for lower extremities to also assist with circulation, and mobilize them as tolerated. Movement is critical in the prevention of DVTs. Problem number 7, comorbidities, hypertension, type 2 diabetes, and hepatitis C. So treatment options could include consulting with a team to ensure appropriate medical management of the comorbidities. This is a great one to use whenever you are talking about comorbidities. You would monitor for signs and symptoms of hypoglycemia associated with the diabetes and exercise. Monitor blood pressure and ensure the patient is at a safe level to mobilize. The BP must be under 200/110. For Hep C, take infection control precautions only as necessary. You would use contact precautions if the patient had a wound that was exposed or if there is any oozing from the dressing, as Hep C is transmitted through infected blood. As a future treatment, when post-op delirium has subsided, you could educate the patient on modifiable risk factors associated with their comorbidities. Whew, okay, that was a lot, right? But if you break it down by problems, it's really easy to create a treatment list when you are relating it to the problem. Okay, well, I hope that strategy was helpful and you use it for all Case 2s in the future that you're prepping for. If you need any help preparing for Case 2, make sure you check out our OCE course.